All right, hello everyone. So we're going to start with some brief introductions. My name is Melissa Anderson. I am a hearing psychologist. I'm not deaf. I work for the University of Massachusetts Medical School. Also part-time, I do see clients. I work and provide therapy directly with clients. I also, part of my time I spend doing research related to how to utilize therapeutic approaches for deaf people and sign language users.
And hello, I'm Tim Riker. I teach at Brown University. Currently, I teach American Sign Language, which also includes lessons on deaf culture. I have been faculty there for over 4 years, and I've been working with Melissa here for her project under Spark. We collaborate with Brown University for the research here as well. Today, we will be co-presenting. You're going to hear the voices of 2 sign language interpreters. They're in the room with us, sitting across from us. Occasionally, there is a little bit of a delay where you might see myself or Melissa signing, and we stop signing, but you can still hear the voice. Sometimes there's a little bit of a delay there. And that's just how the interpreting process works. I wanted to start off by telling you a little bit about myself and my experience with deaf culture and community. And that starts with my family. Both of my parents are deaf. I'm what you might call a second-generation deaf person. My brother is also deaf, but he is a little bit more hard of hearing, which is another term we'll talk about later. When my father was born, he could hear, but at the age of about 3 or 4, he got German measles and became ill. He had a high fever. That's what caused him to become deaf. This was his family's first experience with interacting with a deaf person, so his parents decided to put him in a school where they did not use sign language. They used spoken English and oral training. It was called an oral school. That kind of education put a lot of emphasis on speech and lip reading. Because of that, his language abilities didn't develop as his peers did, his hearing peers. Later, he did attend Gallaudet University. That is the only deaf liberal arts school in the entire world, actually. So when he was in his early 20s, that was his first real immersion into the deaf community, where everybody at the school was deaf or hard of hearing and used sign language. My mother had a similar experience. She also became deaf at about the age of 3 or 4 due to a high fever. And my grandparents, again, weren't sure exactly what kind of education they should provide her, but they ended up enrolling her in the Georgia School for the Deaf. At this school, they did emphasize sign language. The school was probably about 3 or 4 hours away from my grandparents' farm. So later in her education, they ended up transferring her to a school closer to home into a mainstream experience, which meant that she was a deaf child in a school with mostly hearing children. So as you can see, my parents had 2 vastly different experiences growing up deaf. Because of that, my parents really knew how to best choose our education, my brother and I. My parents found a school that they thought would work great for both of us. It was a deaf school. As it turned out, because my brother did have some hearing, he wasn't qualified to go to that school. So I ended up going to the school for the deaf, and my brother went to a different school. But of course, in our home life, we all used American Sign Language. So we all had a very vibrant language environment at home. That experience is different than many deaf people in general. People who have never met a deaf person or who don't know that much about the deaf community might see a deaf person and think of them as having a disability. They might see them as having a lack of ability to hear. With deaf education, when a student goes to a school for the deaf, for example, and they're around other people who sign, including teachers and other adults model to sign, a deaf person feels very much the same as your typical hearing person. Rather than it being a disability, most deaf people see themselves as being part of a unique socio-cultural group, where we all feel, a socio-linguistic group, rather, where we all can interact well together. The deaf identity involves a community and language and a lot of rich cultural details. Earlier, there were some not so nice labels for deaf people back in the 1900s and earlier. Most of those have since changed, and we as deaf people have our own labels that we choose to use. You may see the term deaf used with a capital D, and that refers to this linguistic group. Similarly, when you speak of Spanish or Latino or Hispanic group, you use a capital letter to start those terms as well. This cultural group, we really value our language, our culture, and our history, similar to other sociolinguistic groups. When you see the term deaf with a lowercase d, that oftentimes is referring to the inability to hear or the medical diagnosis. You might also see the term hard of hearing. That's used often for a person who has some hearing. They might even be able to use the telephone or other things like that. Some people prefer using that identity over deaf, and it's really up to the individual. On the other hand, a person who does have some hearing, they might call themselves deaf with a capital D, even if they can use the telephone or they can do some other things with the amount of hearing they have. And hard of hearing is not the same as hearing. It still does involve a hearing loss, so you don't want to assume that a person who's hard of hearing can hear.
And just to add to that, to really emphasize something you mentioned, that the person, the individual themselves, that's the person who picks the identity. They may say, I identify as a deaf person, or I identify as a person who is deaf but not part of the culture, or I identify as hard of hearing. It can be any identity that that person chooses and feels is appropriate for them.
Right. And in my experience, sometimes people's identity is a bit more fluid. So a person in one situation might call themselves deaf, and in another might call themselves hard of hearing. And sometimes that's done as a protection against people who don't understand the identities. So a person amongst hearing people might refer to themselves as hard of hearing, but amongst their deaf peers might call themselves deaf. You've seen the term hearing impaired. A lot of people who are hearing, who do not know deaf people or deaf culture, use that label because they think of it as more neutral or more politically correct. But from the in-group, we don't see that term as being appropriate. It takes more of a medical view. And that's a term that the deaf community has resisted over the years. And you see the artwork now on the screen of some hands that are chained and have some of the fingers cut off. This is one of a piece of deaf art that really shows the history of deaf oppression. So I want to tell you a little bit about deaf oppression. A lot of you have grown up hearing about the inventor of the telephone, Alexander Graham Bell. I'm going to talk about him, but I'm going to tell you something different than what you read in your history books. He's actually well known in the deaf community as someone who has oppressed deaf people. You've probably read about Charles Darwin. You know, he wrote The Origin of the Species, and he studied evolution. From his ideas came the notion of, you know, the genetic pool and survival of the fittest, that people who are born healthier are stronger, and people with less superior genes are inferior to those. During this time in the 1800s, as you know, scientists of the time were white men, and they made a lot of decisions about what the desirable traits were of people at the time. And Alexander Graham Bell was one of the people who was involved in this movement at the time called eugenics. His belief was that the number of deaf people should be reduced or eliminated. And I told you a little bit about Gallaudet University and deaf education. At this time, deaf education was thriving. There were many deaf people involved with teaching at Gallaudet University and as faculty at other schools. There were a lot of publications by and for deaf people. So the community was really thriving. Alexander Graham Bell and the like saw that as a threat to their language of English. They had an English first kind of mentality. At the same time, a lot of people were immigrating from other countries in Southern Europe and elsewhere. And so the English first, English pride was kind of affecting the relationships with these people, including deaf people. So then there was a shift from using American Sign Language in this thriving community I told you about to using oralism, which focuses on speech, speech reading and lip reading. Here are some more artistic pieces here showing deaf oppression historically. And then some pieces of deaf pride, like with the American Sign Language, deaf people can thrive. So one of the essential points I want to make here is that for a deaf child, having a visual environment and having a visual language or a visual tactile language if you're deaf and blind, having this kind of access really does provide equality for a deaf person. And there's quite a variety of deaf people in the community. Some people who do have access to American Sign Language, and some people who have less of that. So you do meet quite a variety of deaf people with different levels of language abilities. And this is all based on their experience with language exposure. For the most part, schools and families do not have access to American Sign Language. So deaf children, really probably about 80 to 90% of them do not have access from the get-go with the first language. So that's why when you meet a deaf person at any age, you might notice that they might have a delay. And of course, that person can catch up once they start becoming fluent in the language. And there are many deaf people who have PhDs and other professional experience that shows that.
And also to add, in terms of us as providers working with people, it is important to understand this history of oppression and to understand the background that deaf people are coming into these provider appointments and our offices, and they don't trust the system. They don't trust the people that are interacting with them, and there is a reason for that. Because of this history of oppression and trauma, it's important that we as providers know that there may be issues that come up while we're providing services.
And as an example, one of my father's experiences, who, as I told you, grew up oral. He went to a restaurant at one time, and, you know, he made his order. He was out with different students, and he was asked to speak. He wasn't allowed to use gestures or signs or point to the menu. So because of that, he oftentimes felt uncomfortable in a restaurant setting, and even as an adult had a triggering experience when he would order the wrong food and say, for example, he would order his food and the wrong meal would be delivered. So these things that happen when a child is young become part of who they are as an adult. So again, deaf people do not feel disabled or different. They have a sense of pride. We value our culture and our language. And that pride sometimes leads to organized movements and protests to make sure that we get our needs met. In 1988, there was a movement called the Deaf President Now movement. And this occurred at Gallaudet University, where all of the presidents up until then had been hearing. And deaf people wanted to see a deaf person in that role. You can see there in the corner one of the pictures. You can see George Vidit. This man was working tirelessly during the time of A.G. Bell to oppose the ideas of people like A.G. Bell and to make sure the deaf community was valued and could thrive and continue. So despite the fact that deaf people have been oppressed, as a community, we have really resisted that kind of oppression and continue to thrive. Oftentimes, people have the idea that if they're working with a deaf person, if they just get an ASL interpreter, all problems will be solved. But there's actually a bit more to it than that. As providers, we should never assume that we know what a person's needs are. We really need to know each person individually and what their experience is. They're the authority on telling you what their needs are. So that could be an ASL interpreter, but it could be some other kind of accommodation. It's also important to remember that because of this oppression and the barriers that deaf people experienced over time, deaf people have had varying experiences growing up. So some deaf people are fluent in American Sign Language, where some are not because they had a different education. So some people might use American Sign Language. Other people might have an English-influenced version of sign or English Sign Language. American Sign Language is its own national language, and it's recognized as a language, whereas English is more of a coded form of English Sign Language is more of a coded form. There's also something called cued speech. That follows sounds of the English terms and uses signs near the mouth and face. That's more of a way of interpreting English and not a language of its own. Simultaneous communication is actually signing and speaking at the same time. At my school that I went to until about the age of 13, a lot of the teachers did use simultaneous communication. Before 1993, there was a model of teaching called total communication that involved American Sign Language and English, but that shifted to something called bilingual education after that. So people realized that trying to use two languages at once was not particularly effective and shifted more to an ASL model of teaching.
And I think it's important to clarify as well that nobody can produce two languages at the same time, regardless of the language. So if you're trying to produce English and American Sign Language at the same time in some way, one of the languages will suffer. The language can't be produced fluently both at the same time. So either the English speech is pretty good and the signing is very unclear and not grammatical, or vice versa.
So many schools that had been using total communication are now shifting to a bilingual approach. There are many deaf people, however, that grew up in a total communication setting. So you'll meet people of all different abilities. It is true that some deaf people didn't have much language exposure at all growing up. So they might not have ever been exposed to American Sign Language fully. These people may have had a lack of any formal language. So you might meet a person who's using more of a gesture or mime or something we call home signs, which are signs that people use within their home or near home settings, but that the average person wouldn't understand. So that can be very challenging to work with a person who's not fluent in American Sign Language. And again, the emphasis is on meeting their needs and making sure you can accommodate what they need language-wise.
So this is, what you've touched on has actually become a really hot topic. It's called language deprivation, and so it really impacts deaf people who, it's very rare, but it impacts people who had no exposure to language or very limited exposure to language. If you think about, you know, the idea many years ago about a person who might have grown up, you know, out in the woods. There's also the woman, the girl who Jeannie, who was a hot topic in the 70s, where the person had no exposure to language and then was found later on. That's very rare. That's within the population of hearing people who are not deaf. Within deaf people, the deaf population, language deprivation is actually much more common. Often, even in my office, when I see people, it's very difficult to assess deaf individuals in terms of what's really going on with them psychologically or to give them a diagnosis, because the assessment process is impeded by this lack of formal language or language deprivation.
It's important when working with a deaf person in the mental health setting that you get an interpreter who has mental health interpreting experience. As you know, the mental health setting has its own jargon, its own vocabulary, and its own nuances. And it's important to have an interpreter who is aware of that. The interpreter would work closely with the psychiatrist or the psychologist as a team to make sure that communication is effective. An interpreter also needs to know when they're interpreting a person who might be having difficulty expressing themselves due to their diagnosis, and the interpreter needs to make sure that they don't try to quote-unquote clean up what they're saying or cover up what they're saying. They need to be able to express exactly what the person is intending. Also, the interpreter needs to be able to inform the provider of any clues they might be seeing as a person in the room that knows the language that's being used.
So as an example, oftentimes hearing providers will put down in a chart or in the record, you know, I can't comment on this particular feature because lack of speech, you know, rate of speech is not available because this person's deaf, as an example. What's really important is that that's not the case. If you're able to work with an interpreter and the person is, for example, they're signing using a much larger space than typical, or they're signing at a very high speed, that is all related to pacing and rate of speech. It can show something about their thought process or where they're at. And so when you're doing a mental health status exam, for example, utilizing the interpreter to understand what is really going on is very important. So you can have a discussion with the interpreter as well as observe on your own and try and clarify if there was anything happening with that person's language during the assessment.
Also, if a deaf person does have language deprivation, an American Sign Language interpreter might not be sufficient. So in that case, you could call in a certified deaf interpreter, or CDI, and this could be in various situations where CDI would be needed. An American Sign Language interpreter who is hearing has training. They have their certification. However, they're not native users of the language. So a deaf interpreter who grew up immersed in the deaf community and in the language brings a different skill set to the table. The hearing interpreter and the deaf interpreter work together as a team to ensure that the interpretation, whether the deaf person is using more gestures, whether they're using visual cues like pictures, they work together to make sure they're able to successfully interpret that information. So the certified deaf interpreter gathers this information, interprets it to the American Sign Language interpreter as they work as a team again. Also, because of the unique skill set of the certified deaf interpreter, they're oftentimes able to catch little nuances that a hearing interpreter might miss. The hearing interpreter can provide a sort of cultural mediation as well, where they have access to information that's readily available in the quote-unquote hearing world, and then they can apply that to the understanding and the interpretation as well.
So we had planned to show a brief video that explains very basically, kind of really basic information about how to interact initially with a deaf person when you do encounter them. I'm going to skip that for now, just in the interest of time, but we'll go back if we have time, or you can go ahead and watch it yourself on YouTube. I highly recommend it. It's very brief. It's National Health Service in England, actually, is the one who produced that video. It's probably a 4 or 5 minute video, and it just gives you a nice idea of how to approach a deaf person, just if it comes about unexpectedly, etc. So you can go ahead and watch that on your own and disseminate that, because it might be really helpful to other providers as well. But we'll hold off on that for now. So oftentimes one of the things that people misunderstand is that deaf people would have different diagnoses or different mental health needs, etc., than the rest of the population. I see this very often. But really what's been found in research and study about this is that mood disorders, anxiety disorders, that type of thing, affect deaf people and hearing people. They don't have different types of diagnoses. The difference is the modalities in terms of how treatment comes about. So for hearing people, it's less complex. Treating deaf people is more complex. So often we see the NOS diagnoses in charts and things. And that really is supposed to be a catch-all for things that don't quite fit in an exact diagnosis, etc. Oftentimes it's something that's put down in the interim because we know that the person has some sort of mood diagnosis, but we're not sure exactly at this point, and we might put a mood disorder NOS as their working diagnosis. But the problem is with the deaf community is we see that that is extremely common with deaf people and far more common than it is with hearing people. There's a few reasons why that happens. Hearing clinicians may be unaware of deaf culture. They're not well versed in it. They haven't been trained in working with deaf people. They don't understand sign language. Another reason is language deprivation, as we've mentioned, and the different kinds of backgrounds that deaf people have can make it hard to get a good assessment. So in an example where you're assessing somebody and there's a lot of communication issues happening, why are those communication issues happening? In the hearing population, it might be due to a psychological reason, or their thinking is unclear, or maybe they're experiencing psychosis, or it could be a biological problem happening, dementia, something going on with their thinking. But in the deaf population, is it language deprivation? Is it a language issue? Is the appropriate accommodation not been provided? Or is it really one of those other things? Another thing to understand is that deaf mental health has really not been researched and studied at the same level as other populations. It's a very young sort of field. Probably 10 to 20 years of research at most has been done. What we do have does make it look like there's a higher incidence of mental health diagnoses in deaf populations versus non-deaf populations. But the point to understand is that may be true, but more research is really needed to know for sure. Oftentimes hearing people think, well, a deaf person can't hear, so there's no way that they would have auditory hallucinations or hear voices. What's interesting is that many deaf people do report that they hear voices. What's important to keep in mind when assessing these things is understanding what that might mean for deaf people and how that might be different for them. The concept of hearing voices is hard to understand and interpret because how people experience this and report this is very varied. Is the person hearing of voices? And when we're using the signs to represent the sound, so for example, let me give you an example. So you're assessing a deaf person and an interpreter is brought in. How does the interpreter represent the concept of hearing voices? Are they interpreting it as physically hearing a voice, say, through the ear? Are they saying that there are sounds around the person's head that they're experiencing? There's many different ways to represent the concept of hearing. If the person is the person reporting that they're hearing voices, or is it maybe something else that could be a miscommunication? One thing that can be helpful is finding out what types of sounds that they're reporting. Are they hearing a male voice? Are they hearing a female voice? Are they having command hallucinations that are telling them to do things? Asking them very specific questions about what it is that they are calling hearing voices is what's going to lead you to hopefully to what's really going on.
And as I mentioned before, people in the deaf and hard of hearing community have various levels of hearing. Some people can hear somewhat, and they might be able to hear a voice. Also, from the cultural perspective, a deaf person might themselves interpret that differently, whether or not they can hear a voice versus a hard of hearing person. So the person's own ability to hear can affect that interpretation of the concept of hearing voices. So you might even get some answers to that question that themselves are a bit complicated.
Another thing to be aware of is that often people experience tinnitus. Deaf people often have tinnitus, and they think it is a hallucination, or they don't know what that sound and experience is. Something else that comes up is that deaf people or hard of hearing people who have used hearing aids, especially in the past, older styles, especially older styles, but even now, would get sensations from the hearing aids, and it would create sounds in their ears, and it was really what we call feedback. It's just like an electronic feedback sound, and doctors have diagnosed deaf people who had sounds coming from their hearing aids as schizophrenic or other diagnoses. So it's very important to understand what's really going on and to consider all of these other factors. And it's also important to understand that when we see deaf people come in for assessments or in the office, we see this laundry list of diagnoses. I mean, pages and pages of different diagnoses. And so what's happening, it appears, is that they're being overdiagnosed and inappropriately diagnosed, and then the incorrect treatments are provided because people that are, the providers aren't aware enough about the person's history and what might be going on with them. So I did talk a little bit about communication issues and things, language disruption. So something to understand is that sometimes when a deaf person has language deprivation, their language is so impacted that they can appear psychotic. They can appear that they're in psychosis because you cannot understand what they're reporting to you. It doesn't make sense. The timeline doesn't make sense. And sometimes it's not an emotional problem, but the story comes across that way. Sometimes they do have the issue of emotional and behavioral things going on as well. So it's hard to parse out, but you have to sort of pull apart what is happening with them language-wise and then what is happening with them emotionally and behaviorally. But they can appear the same. So just to touch on a few specific disorders, I'll start with bipolar. It's often what we see is rate of speech cannot be assessed. And we also see the notation of because they're deaf and mute. So let me clarify that. That is very often in medical records. Please don't put that down in the medical record. Mute is a word that we don't want to use for deaf and hard of hearing people at all. If the person is signing, they're not mute. It means that they are able to express themselves, but it's just a different communication mode. So you want to work together with the interpreter, if that's the accommodation being used, and find out what's their language look like, and of course an interpreter who's well versed in this, but use them to get feedback on the person's language as well. It's important to not look at a deaf person and see the way the person's signing and making facial expressions and banging on a table, perhaps. Those are all normal ways that deaf people would communicate. They might bang on a table or wave their hand in the air to get someone's attention. They use facial markers, which are actually grammatical features of ASL, body movements. All of that is going to be all within the realm of normal communication in American Sign Language, and you want to make sure you don't pathologize that.
Sometimes, too, in American Sign Language, people, when they talk about past tense, a different time or a different place, it's very typical in American Sign Language grammar to show yourself as that person. You take on the role of that person. Also, a lot of American Sign Language grammar is shown on your face. So if you are taking on the role of a person and explaining how the person was angry, you yourself might look angry. So without a clear understanding of American Sign Language or clear interpretation, a provider might misunderstand those facial expressions as that person's anger, etc.
I do see that we're getting close to the time for questions and answers, so I would like to hold a few of these things and just touch on the most important pieces I want to make sure we get to. I did focus on depression here. I do want to mention that oftentimes deaf people would have a different fund of knowledge, different vocabulary based on the things we've talked about, history of oppression, language deprivation, and very varied educational background. So I just want to give you a quick example of this. What we have on the slide here gives you just an idea of different types of things that can be used. You can use technology to show videos, utilize different pictures. Here we have drawings to visually show concepts that might apply to different types of symptoms they might be experiencing, because the client you're working with will often nod their head. They're just watching, they're taking in the language, and the provider assumes that they understand or that they're affirming something that the provider has said. when in actuality they may just be, quote unquote, listening to the provider. It's important to use different modes that might work for the person, and then also check in with the person. Like, does this make sense to you? Ask questions to verify for understanding. So right now it's 1:49, so I guess we will open up an opportunity to ask questions or have a discussion. Make sure we have time for that.
Okay, let's see. We do have one question came in. One viewer asked if we could discuss a little bit PTSD and trauma with deaf children and what clinicians can do in terms of intervention and assessment, or assessment and intervention.
Okay, yes. I think I just made everyone dizzy by going all the way back through the slides, so I apologize for that. But I wanted to go back to the applicable slides. So that's a good question. What we've learned about the deaf community is that the rate of trauma is about double compared to the hearing community. So, for example, in the hearing population, women is about 25% experience of domestic violence. Deaf women, it's about 50%. So the rate of trauma is so high in the deaf population that it's, unfortunately, you have to safely assume that any woman that's coming into your office is deaf has experienced trauma, for sure. Men as well, deaf men as well. So unfortunately, that's the assumption that can be made. The research hasn't been done as much on deaf men, but it has been done on deaf women. But what we see is that trauma is very common within the deaf population, very high percentage. Anytime you meet with a deaf person, you're providing services to a deaf person, you should assess for trauma. It's important to not ask the question, have you experienced trauma? That's not going to get you the information that's going to be most helpful. So asking questions that are more related to specific examples. So let's say it's domestic violence. You could say, you know, has your partner ever hit you, slapped you, kicked you, swore at you, insulted you, etc. To give examples of behavior is really the best way to assess for trauma or leading into any diagnosis. To get really concrete examples is really where you're going to get the best information. Many deaf people don't know the word trauma, or they know the word, but they don't really understand the concept, and they may not be familiar with it. Even if you're providing treatment for, let's say, depression or some other diagnosis or issue, it's always good to take a trauma-informed approach, because we have to assume that this person is probably a trauma survivor. It's important to pay attention to what might trigger that person, and also to create a really safe space for them. Did you want to add anything to that, Tim?
I would just say that it is important to be aware that deaf and hard of hearing people have all experienced barriers and oppression, whether or not they have experienced a specific trauma. All of these things can be traumatic, so it's really a complex set of issues that you might want to talk about with your clients.
Many of us are aware of the concept of microaggressions. The idea is that, the discrimination that we see now is a little more subtle than, say, 50 years ago. Hopefully we'll continue on that path. But the discrimination does still happen, but it's in smaller, more subtle ways, but it's continuous. And so what it does is it builds up. And that's true of any population who experiences microaggressions. That's very true of the deaf population as well. So as a deaf person, you have these microaggressions, you deal with that, you deal with the other things that are happening in your life, and then if you have trauma or mental health issues, then it's piling up and it becomes a lot on the person. So it's good to be aware of. Are there other questions?
We have one other question, and that is one of the viewers wants to know if you have any tips or advice to provide a good training to the deaf and hard of hearing individuals. This is someone who works with that population.
So can I just quickly clarify that question? Maybe this person could help us clarify. Do you mean a training that is geared towards deaf and hard of hearing people? For them to attend the training?
We believe so.
So I'm a professor, but I'm also a certified deaf interpreter, which I spoke about earlier. There are a lot of deaf-run trainings for self-advocacy. The deaf community has a very shared learning approach, shared information approach. So what happens is one person from the community will share the information with others, but not necessarily in a formal setting or a formal lecture. A lot of the education that happens in the community is peer-to-peer or peer-led or peer-facilitated type of education. And this seems to work very well culturally for this community. Again, it's very much a shared experience community, very collaborative in that sense. That's just part of the culture and part of the way that people survive.
So maybe it would be, so whoever asked that question, maybe it would be good to set up that type of training, collaborate with an established organization of deaf people working with trainers and deaf people, so that you have a collaborative approach between, wherever you're coming from, and then an agency, organization, individuals with that type of very specific experience that know how to make it deaf-friendly.
Communication Services for the Deaf did have a survey. It was quite entailed, but that did show that the peer model, groups led by deaf for deaf, and an interactive model, including lots of different materials as far as visuals and other disseminated materials in other ways.
And also teaching with stories. I know that was, I forget if this was already mentioned or not, so forgive me, but a big part of deaf culture is what's called the oral tradition. Not oral in terms of oral education, which we've spoken about today, which is spoken language, but the oral tradition of passing down stories and information through generations using American Sign Language. So telling stories, and they go through the many generations. And this is similar to other cultures that have no written language and they use an oral tradition. It's the same thing with American Sign Language, no written form. So that oral tradition, storytelling, is really something that works well for them as well.
Right.
Okay, are there any other questions?
Actually, we've had a couple questions come in. One is asking, when will the Seeking Safety deaf-centered approach modification be complete and available for purchase?
Great question. So that question, just to clarify for other people, is related to a project that I am involved in right now. Seeking Safety is it is a paper treatment manual for treating trauma and addiction combined. So what we've taken on as a project to make it more deaf-friendly, to make it more accessible so that the tools are accessible, the manual becomes accessible to deaf people as well. It is a little, it's like an educational soap opera is basically the structure. So it teaches all of the information through deaf storytelling, peers, etc. A little bit of what Tim had mentioned prior. There's some different, hands-on materials, different types of things, but we've sort of turned it into this educational soap opera using all of these great ways that the deaf community learns best. We're in the process now, and we want to find out from deaf people if they like it, if it works for them, what kinds of improvements can be made, and we're going to go ahead and refilm it and do all of that. We've already done that first round of testing with the population. This is one of the problems with research, right? It's a great opportunity, but it takes forever. So we're going to be going through the second round of filming and then retesting it. We want to make sure that what we're making is safe and effective. We didn't want to rush through and just disseminate this thing that we kind of came up with quickly. We really wanted something high quality. So we're hoping it will be available in the next couple of years, 2 to 3 years. I know that's a long timeline. The deaf tools will be free and downloadable, though. We don't want to charge anything for those. We'd like to make those as accessible to anyone who could use them as possible. I will continue to share updates on this process, and I really appreciate that question. Thank you. So with that, it looks like we're right at 2 o'clock. I don't know if we have time for more questions, or what should we do next?
We do have another question that had come in asking if you can recommend classes or programs for hearing clinicians to develop, actually to better assess deaf clients or to develop the skills to do that.
I'm more familiar with an interpreting training program, and this is in Troy, Alabama, for mental health interpreting. I'm not so much familiar with trainings for clinicians.
Well, I'm going to have to think about it. It also depends on where you're located. The first thing that pops into mind is Gallaudet University, of course. Their graduate level program they have clinical psychology as a program. They also have a master's in mental health counseling program, so that might be possible in terms of taking 1 or 2 courses just to get a good understanding. That's located in Washington, D.C. If you're talking about locally here in Massachusetts, I would say Boston University, their Deaf Studies program. They will sometimes have psychology of the deaf class offered, and also counseling and the deaf offered, and both of those are within their master's program, I believe. So those are the 2 options I can think of right now. If those are not in your area, please feel free to email me and I can try to help you locate something else. Are there others, Tim? Am I missing any?
Webinars are popping up more often now, and I know a lot of universities do offer short courses through the internet, for 1 hour, 2 hours, similar to what we have done today. So that kind of professional development training. Lots of times, conferences provide interpreters and cards for deaf attendees. That might be another way to attend a conference to find out some more information, but I can't think of a conference now off the top of my head. Can you, Melissa?
Well, there's one conference related to mental health and deaf people. It's under an association called ADARA, A-D-A-R-A. This year's conference will be happening, I want to say, the end of May, and that will be in Portland, Oregon. I'm trying to remember the sign for Oregon. Thank you, Tim. That conference is specifically focused on how to provide services to deaf clients. So it's ADARA. ADARA. If you look online, you should be able to pull that up, and then maybe there's some other resources listed along with it.
Also coming up in 2018, I almost said 2008 there, 2018, next year, I'm working with a group that will be hosting a National Council for Deaf conference. That's going to be in Providence, Rhode Island. That's affiliated with Brown University and collaborating with the Rhode Island School for the Deaf. I think that one might be geared more towards school counseling, but it would definitely have a heavy mental health aspect to it.
And I just want to say, please feel free to contact either of us or both of us with questions, or if you want more resources. I'm going to put our contact information on the screen now.
Okay. So that's it for today's webinar. We want to thank Melissa Anderson and Tim Riker for this presentation. The slides and today's webinar will be posted on Spark's website soon. Please be on the lookout for email announcements for future Spark and Transitions RTC webinars. And please don't forget to visit our Spark website to join our mailing list. And thank you for all who attended.
Thank you very much.